Welcome to Week 3 class. This week we will dive right into patient records and the responsibilities of providers and patients. We also will discuss the differences between administrative and clinical data, the process of correcting inaccurate documentation, and storage methods. Once we complete Week 3 activities, you should be able to accurately list the various components of inpatient, outpatient, and physician office records with the ability to distinguish between each. We have a lot to cover, so without further ado, let's go ahead and get started. Each of us has a patient record containing clinical and administrative information about us, but at a very basic level, what is the purpose of a patient record? By definition, a patient record serves as the business record for a patient encounter, contains documentation of all healthcare services provided, and is a repository of information including demographics, diagnoses-based documentation, and treatment results. So we can boil all of this down to simply stating that this record is the administrative representation of our continuum of care across our lives. Ownership of these records resides with the organization or provider that the patient or you seek care from. Patients have, by law, the right to access contents, but ownership resides within the care organization itself. With meaningful use requirements, among others, a majority of healthcare venues operate off of an electronic health record system. This transforms patient data into a digital representation of their record. There are many different types of records, though, so let's review the most common. Hospital inpatient records will contain all health interactions that take place while a patient is admitted to a hospital. Inpatient admission timeframes vary greatly depending on the cause of the illness, but typically they are between 6 and 8 days. Let's translate that into what a record looks like after this encounter. Think of all the labs, procedures, routine checks, etc. that take place. Patient records grow quickly during these types of encounters. Note that there is a difference between the types of data collected, though. Data can be classified into roughly two categories, administrative and clinical. A lab result is an example of a clinical data element. A patient's physician is an example of administrative data. Hospital outpatient records contain documents relative to patients who have not been admitted to a hospital but have received services there. An X-ray is an example of this type of record. Physician office records consist of all documents relative to your visits with your general physician. Alternate care settings house documentation related to services provided by ancillary care organizations. This type of data can be found in this setting can vary widely depending on the purpose of the visit. For example, a behavioral health visit contains a lot of information similar to inpatient visits. That said, there are significant differences necessitating a different record structure. In the opening of this lecture, I stated that providers have responsibilities relative to patient documentation. Let's examine this topic a bit more in detail. The Joint Commission provides a very clear policy stance that only authorized individuals can make entries into a patient's health record. AH112 actually takes this a step further by stating that only credentialed professionals with appropriate rights and authorities should access charts. The burden of access needs is directly related to a provider's purpose with that patient. How are items authenticated, though? Given this strict guideline related to access, we have several methods of authenticating patient record entries as shown in the list below. I must take a moment to note that, with the proliferation of electronic health records, a majority of authentication actions occur through the EHR exclusively. That is not to say that all authentication actions occur this way, but it has become more and more common throughout time. The Joint Commission also requires that patient records be complete, fully documenting the entirety of a health encounter within 30 days post-discharge. Abbreviations are incredibly common and make chart reviews somewhat difficult, so let's take a moment to review a sample abbreviation list. Patient records are developed or created through many different sources and scenarios. The inpatient record encapsulates the activities that occur from admission to discharge. Most patient records are structured in reverse chronological order. This simply means that the most recent piece of documentation is listed first. In the outpatient venue, patients are seen on a more frequent basis, and records must be retrieved and grow with each of these visits. A patient record in the physician office provides the ability for these records to assist with the continuity of care for a specific patient. Think about your record with your doctor. It lists when you last had a sinus infection, hurt your foot, had the flu, or had an abnormal lab value returned after a blood test. This is really a hub for your patient information. We've had a healthy conversation about patient records in general, but now let's turn our focus towards how these records are formatted. Primary sources of documentation are those documents provided by a healthcare professional during care of a patient. Secondary sources are those bits of data abstracted from primary sources. These consist of indexes, registers, and incident reports. The first two we've explored briefly in prior weeks and we'll dive into more detail in the coming weeks. An incident report, though, is a document that lists something that occurred during the care of a patient that was adverse in nature. Think medical error, for example. Now that we've spoken about sources, let's cover structure. Source-oriented records, or SOR, is a more traditional formatting method that structures a record based on the source of the documentation. All nursing documentation is grouped together, for example. 9 times out of 10, I see this at healthcare organizations across the country. Problem-oriented records, or POR, are a format that breaks a record into 4 categories: database, problem list, initial plan, and progress notes. The database consists of basic intro data like social data or your diagnosis. The problem list is filled out with issues that require diagnostic review. The initial plan lists the actual action plan for treatment of a patient. As you can imagine, this can be very detailed in nature based off of the treatment category it falls under. An integrated record format is a patient record that lists activities in strict chronological order. Next up, the cheddar structure, shortened obviously, is designed to force consistent, detailed habits of providers when they walk through their workflow of documenting. Lastly, history, physical impression, and plan, or HPIP, are almost identical to SOAP notes for those that are familiar with them. There's a logical sequencing similar to others that we've reviewed, but again, it's all about providing a structured framework for providers to work from. There are a few other topics related to record structures and formats as shown in this current slide. Be sure that you review each in their entirety prior to the end of week 3. You've heard me mention a few times already that providers have a responsibility to ensure that records are as complete as possible. This group, however, is not the only one that this responsibility resides with. The governing board and facility administration are also responsible parties. The board is responsible for facilitating a first-class care experience for patients. Facility administrations are directly responsible for ensuring that the staff adopt rules and regulations that are geared towards creating complete medical records. They are the enforcers of the specific organization's policies. Attending physicians and other professionals bear the majority of the responsibility for the completion of a patient record, but this is all important information to understand as we move forward. Now, obviously, this is the topic where the HIM department shines. HIM departments have a large role to play in ensuring that records are complete. The Health Information Manager is out there educating staff regarding proper documentation processes. At the same time, HIM staff members are also assisting with the design of these processes as well as auditing charts to ensure that they are complete. The bulleted list on this slide outlines the exact efforts that this critical department performs, but the core of it is accuracy and completeness. This concludes our review of Chapter 4. We've covered a lot of ground, so let's take a moment and recap. During this lecture, we reviewed the different types of records, various types of content found within these records, and the professionals that are responsible for ensuring that they are complete and accurate. This basic understanding will be incredibly vital in future weeks, so make sure that you thoroughly review this material in depth.